We are now live. We are recording. So I'm going to do a screen share so that we can start with this one. And everybody should be able to see the Power of Patience logo. We have that?
Yeah.
Okay, awesome. So I'm going to move on down. We have Dr. Almirati. She's our rock star, as you know. She presented at the last conference, and she, along with Brian Gurry and Alex Becker, who has also been doing some vision therapy, she will be running through a brief overview of today's webinar, which was the intake, and let you guys do it. So so let's just get started. So what we have here, the goals is, if you didn't get to see the last webinar, go on our website, go onto the dashboard, and you can see her webinar number 1 of the 3. Today we're going to learn what tests can be done for certain kinds of therapies, and then you're going to get to try it at home today. So with that, I'm going to let Dr. Almirati go ahead and start with the first one, and then I'm going to queue up the video to show you Brian.
Okay. Could you make it like a presentation the full screen, just because it's a little small?
Yep. Oh, sorry, you guys.
There we go. Perfect.
Okay.
So thank you everyone for joining. I'm Dr. Almirati. The first couple things we're going to be talking about is kind of like going back to the first webinar, just as a refresher. If you're new, we'll go over it in here as well. Feel free to ask me any questions. So we basically took 3 different eye teaming issues that are some of the most common issues that happen in TBI and highlighted them. So the first one here is saccadic dysfunction, which is an eye tracking issue. So saccades are very small eye movements we make when we move from letter to letter or word to word as we're trying to track for reading. Gross saccades are when we are trying to track something larger, a larger object like a baseball or something bigger than just text. And so this takes a lot of eye alignment in order to occur precisely. And so both eyes have to be working in sync as you are tracking and moving them from side to side, and then zigzagging back to the beginning of the next line. And so any problem with both eyes not functioning exactly in sync will create a lot of reading issues, comprehension issues, because you're working so hard to just stay on the same line that content is lost by the end of the paragraph. And so what is on the screen right there, that's one way it could look, where words are kind of moving or jumping on the page, or they just don't look straight. There are a lot of other ways that you can see this as symptoms with your eyes, but this is one of the most common one. So next slide.
Well, do you want to show the video first?
Yeah,
Right?
let's go.
Okay, so let's go ahead and do the video. So now I'm going to pop this up, everyone. So just be patient for just a second here. Oh, I have a lot of things open. And let's see. Hang on, this is his number 2 intake. So hold on, because again, as I told you, we've got 2 of them going. All right, and here is Brian Gurry. And oh boy, there's me again. All right, so right here,
So as Lynn is popping it up, I just wanted to let you know, this is it's like a snippet of a series of different tests that are done on saccadic dysfunction to pinpoint it. Some of this stuff you can actually do at home just to screen yourself to see if it's worth getting an evaluation to rule out some vision issues. Some other stuff are difficult to do. And so we try to put things that are a little bit easier to screen at home. So we'll let you know which ones to try at home and which ones to not.
So did you want to have them try this one, to take their pencil or their fingers and to do that and maybe walk them through?
Yeah, so let's see the video first because it's a little bit easier to see it being done first, and then we'll do it ourselves.
Okay, did that video not show you guys?
No.
No.
Oh, crap. Okay, well, hold on now. Let's do it again. Sorry about that. That's crazy because I just played it. So can you see Brian up there now?
Yes, there it is.
Okay,
Right.
all right. So now we're going to hit play.
If Brian's wearing a hat, I see Brian.
Oh, it went forward. Sorry, you guys. Sorry, you guys. Okay. Okay. So I'm
Okay.
going to stop there, you guys.
So this first part, we are looking at pursuits, which is a foundational vision step before saccades. You're basically looking at a moving object, and the you can't see it on yourself, but if you have like a caregiver or someone else who can look at your eyes, they would be able to see whether or not you are following the pen or if your eyes are kind of trailing where the movement is. So we're going to start right in front, so align it with your nose. If you don't have a pen, you can use your finger. And then just look at the very top, so the tip of your finger or the tip of the pen. You are going to be, so here is arm's length. You're gonna bend your elbow a little bit more. It's, you don't want it way too close to your nose, so a little bit like this, turn around. And then you want to keep a steady pace and slowly move it to your left. Don't move your head, only your eyes. And then you want to follow it as it's moving to here. We're going to make an H. So you start here, go to the left. You're going to stop at your shoulder width. So don't go further than that. And then you're going to slowly go up, follow it as you're moving, and then go back down. So that's one part of the H. Now we're going to go to the other side. Again, make sure you're not moving your head, only your eyes, and then go up, go back down. If at any point you saw your finger or the pen splitting into two or turning too blurry, if it's different than looking straight ahead, then that is one indication that your eyes are not moving in sync in all these different directions. And of course, you need all of these directions for activities of daily living, as well as for reading. You could see it double as well, but that is a little bit more extreme. So if you are seeing it double, you most likely already know that you have double vision.
So you guys, I want to add in here, so because I'm the caregiver for both of my daughters, and Brian has had about 8 TBIs and steel in his eye. Now he's a mess, but one of the things that he shared with me during this exam was that his eyes were watering profusely through many of these tests that Dr. Almirati had him go through. And that's another sign of eye dysfunction, right? It could not just necessarily be eye allergies. And he would also say to me how during much of his exam, so I'm just kind of tossing out all sorts of things because everybody is different. During much of his exam, his stuff disappeared. Like the pen went away and then the pen came back. So we just have somebody else to admit. So I just want to kind of let you know, whatever you are experiencing is unique and different for you. So don't think that it is only one thing, okay?
Yeah, absolutely. There's a lot of different symptoms that can happen from it, other from the objective findings of someone looking at your eyes and seeing whether or not they're moving in sync.
Yeah. And I saw the email, the chats about helping you all find the dashboard video. So at the end of this, I will walk you through on the dashboard where the videos are from Dr. Almirati's last month's webinar. Okay. Now I'm going to go back to screen share, and I'm going to go back to the PowerPoint, and then I'm going to give Dr. Almirati the refresher for what we're going to do next. And if anybody has any questions, please holler. Okay, so I tried to make this one bigger.
Thank you. Okay, so the second disorder that usually happens with TBI and vision is accommodative paresis or accommodative disorder. And so this is an eye focusing problem. problem. There is a series of different issues that could happen. You may have only one part of it or all of it. Our accommodation is basically how our eyes focus, our pupils focus in different distances, and also the stamina of focusing up close. So now this is different. It's not focusing versus lack of attention. It is actually just eye focusing. And so just like a camera lens, your pupils relax when you look far away in order to keep things clear. And then when you are looking up close, they constrict. That constriction could be lost or damaged through traumatic brain injury. And so it is something that we can rewire the brain through vision therapy to teach again. It is usually something that is developmental. We're never taught how to keep things clear, but we can reteach it when it is lost to TBI. The symptoms here are intermittent blur. You can be clear up close for the first 2 minutes and then things start getting blurry. It can be blur for a long time. So intermittent isn't like 1 second on, 1 second off. It could also show itself as intermittent blur when you're looking at changing distances. So if you're looking far away, then at the computer, if you're looking at your page, something up close and then to the distance, one of those two could be blurry every single time. And it's because you don't have the flexibility of that quick change. So that's in a nutshell, that's accommodative paresis. Again, blur looks different for each person. So it doesn't have to be illegibly blurry and that's the only way it can happen. Any kind of like, if it just looks funky, you're just like, no, I was clear a second ago and now I'm not. That's enough to warrant you noting intermittent blur.
So I'm going to queue up this part of the exam. Let me back it up a little bit more. And I want to add something, and is it okay if I add something, Dr. Almirati, about age and accommodation? So, I myself, as I'm older, I have to I don't wear bifocals often, but if my eyes are tired. And so sometimes I have heard doctors say to people, oh, it's just because you're aging and that's why you aren't having this accommodation work correctly. Not true at all. So I don't want you to be discounted by saying, oh, well, I guess it's my age. Not at all.
It is different. So there is merit to that. So when we do the evaluation, you have to be in your best correction. So if you're wearing bifocals or just reading glasses, we would do the evaluation over those reading glasses. So that part is to get you to 20/20 up close because of an age-related change to your accommodation.
Yeah.
But that is, as you'll see in this video, that is completely different than having accommodative paresis due to your TBI. And so right here, Brian is wearing his reading glasses. He's already in his best correction. And so that part is okay. Of course, you're not going to be able to keep clear all the way to your eye like this, like a 7-year-old, but that is not what we're looking for in this particular
all right,
portion.
So I'm gonna play the video here so y'all can see it.
So basically what we're doing here is he has one eye closed and then he's going to be bringing a letter close to his open eye and then tell me where it becomes blurry. And so we are looking, each person is different, and depending on the age, that number would change. How far that would actually change depending on normative values. And so, but at the same time, when we are looking here for any inequality between both eyes and when he can clear it. So when you're looking here, you see the first eye. And then, so he was about, let me see.
He was 6 inches on that one.
And so there was a big difference between both eyes. So it was, I have 4 and 6. So the right eye was 4 inches and the left eye was 6. And so that discrepancy alone causes a lot of issues. If you're clear with one eye, so you're getting clear visual input up here with one eye and then back here with the other, it's going to create a lot of overlapping issues and a lot of lack of clarity, lack of precision when you're reading or you're looking at something. And overall, after a day's work, your eyes are going to be extremely fatigued from that.
So I want to take a pause because somebody asked a really great question. But before we do that question about the pupils, I think we were going to try to do this. It's a little tricky, but if you don't have a piece of paper, you could even use your cell phone. Wasn't that what we had talked about,
Yeah.
Dr. El-Moradi? So
You
just,
can
and
open
if you,
a text
and you can
message.
just cover your one eye with your one hand, and you're looking for distance, right? So if you're covering an eye, and isn't it the same, about the same distance with a slight bend in the elbow?
So you want to start at your arm's length. You want to make sure you're wearing your best correction. So those reading glasses or bifocals, if you're wearing bifocals, make sure you're looking through the bottom portion. So you might need to bring that paper a little bit lower so you can see through the bifocals. Cover with the palm of your hand, not with the fingers on top like this. And then start at arm's length. So it might be blurry at arm's length. So you just start there and see. If it is blurry at arm's length, move it a little bit closer. If it gets more blurry, then switch to your other eye. If it gets better, then keep going until it blurs up again.
How big should the letter be?
Go ahead.
How big should the writing be that we're looking at?
About font 12. And so, yeah.
That's a good question.
Your phone, if it's
Did you want it to get blurry, clear, blurry? Is that
no, so we're looking at that first blur, but some people are different. So if it is blurry a little bit further, move it closer. It just depends on the prescription.
okay?
Okay, and then you don't have to have a ruler to know exactly where that is because we're not doing the actual testing with numbers. But basically, when you stop at that first blur, keep holding it in the same distance and switch eyes and compare. Is it clear there? Can you still move closer with that eye? Or is it too blurry, you have to move back? We are looking at any discrepancy in the distance between both eyes.
Mine are different.
Like where it first starts to blur, or where it's so blurry that you can't read it?
When it first starts to blur.
Okay.
Yeah, when the letters start to get fuzzy.
All right.
So this is really, really interesting. So you guys, just so you know, with me, I do not have a TBI, but I do wear contacts, but my one eye is undercorrected and my other eye is slightly overcorrected. And that is so that I don't have to wear reading glasses throughout the day.
And so that is a little bit different. If anyone watching this has that, they're wearing, it's called monovision, to make sure that one eye, it will actually be blurry up close because it's not corrected for reading, then you wouldn't be able to do this test until you take off your contacts and wear your glasses, if you have some reading glasses. So that's very important. So good point.
And what I did for
correct answer out of that.
And what I had to do for Dr. El-Moradi, if anybody uses her, is I just had Brian's doctor with his eyeglasses, and it was, I think, like a year ago, and they emailed us, and we sent her all of the information about his eye exam. And then she knew exactly where the eye health was and the prescriptions and things like that. So I have two really good questions that I have to interrupt so that we keep this discussion going. And the first one, I have to add to it, Dr. El-Moradi, I'm sorry, but you know me, right? I'm going to read it out loud. What is the significance of pupils of the eye being different in size from each other, and what do they indicate? Now, the reason I'm very passionate about answering this one is that my daughter, that was what I kept saying for a year and a half to the doctors. And this is from Leroy. Leroy, it's a great question. My daughter, her pupil was so enlarged, you could barely see her iris. And the other one was always so tight. And for a year and a half, and I would bring this to the doctor's attention every single time we had to go to these doctors, and they just kept saying, oh, it'll get better. Well, until we saw Dr. Davis, which was, is part of, well, she's not part of Dr. El-Moradi's practice, but she is Natalie's doctor, and she and Dr. El-Moradi were working together on this seminar for us. Until we saw her, we then were told Natalie's vision of this eye that was so dilated was as if she was looking through a paper towel tube. So she had no field of vision whatsoever. And that goes into the second question. So Dr. El-Moradi can then, can technically answer both of them at once. My vision is fine. I have perception problems. I don't always perceive things coming from the left. That is my issue.
Mhm.
So,
Okay, so the first question with the pupil size difference, that depends on when that happened. If you have had that all your life, because there is a congenital portion to it, then that is completely different. So if you, I don't know if you want to, if you can type up what happens, you know, or tell us, did this happen after traumatic brain injury, or have you always had that difference in pupils?
all right, while we're waiting for Leroy to answer, the other question is the
Sure. So with the pupil differences, a lot of things can happen. And that's why in the annual exam, just the general eye exam, that is something they look at with lights. So they would shine one light in one eye and then the other, because both eyes are connected neurologically to the back of the brain, where there is one crossing point where all the nerves are crossing from both input of both eyes. And so to make sure that that pathway is intact, we do the light test, and that's in the non-vision therapy, just the regular eye exam, to look at discrepancies there. And so after a traumatic brain injury or just a trauma to the eye or the brain, there are different things that could happen, such as the optic nerve can be crushed, different things that would cause that. And so that's why, like Lynn was saying, I would need, before doing an evaluation, I always get everything else, any other data that was done, any MRIs, annual exams, because if there are findings that are from an ocular disease that has happened to the back of the eye, then that would be something that we might not be able to do vision therapy on. If the optic nerve, for example, is completely shot, then that organ is not working. And so we wouldn't be able, that pathway isn't clear for us to rewire. And so that is one part. There is another portion where we can fix it. So it really just depends on what the cause was and what the MRI shows. So it's a loaded question. There's a lot of different answers.
So Leroy did answer. It happened after his TBI. It
Okay.
was 15 years ago, his TBI, and he is being referred to a neurologist. So I guess, you know, to me, Natalie was able to get her pupil to start working again. And it was you know, immediate. It does not constrict and dilate to the exact same level of her right eye, but it's way better.
Not walking around with one huge pupil and one tiny.
Right.
Okay.
And that really messed up with sunlight. Like she had to wear sunglasses inside the house because it was just very painful.
So the bigger the pupil is, the more light sensitive the patient is, because now instead of a tiny area where the light comes in, it's almost your entire eye. That's a lot of light to take in. So that would definitely hurt.
Okay, do you want to talk about, and I know we're almost up to our time, do you want to talk about the left to right? And then I have another really good question.
Yes, the left and right. So we will actually address that in a couple more slides when we talk about information processing. Okay. That is different than visual efficiency. So now your eyes we're not talking about you tracking and things like that. We're talking about your perception of the stimulus, which we have a very specific explanation for in a couple more slides. So hang tight.
Hang tight. Okay, to be continued. This one is, my vision was always perfect. After my TBI, my eyes hurt so much, and she saw lots of different eye doctors, but her vision feels as if there's an oily film, and it comes and goes, and it's hard to explain, and they jump. Feels like my eyes jump. It looks like.
Here, fuck.
So it feels like the eyes themselves are moving or jumping or in pain.
That's what it said, yeah.
Okay. Yes, so again, we would have to have a little bit more history, and if she's seen a neurologist and you know how that looked like. But if that film is something like it's blurry, like you have some sort of filter on top of your eyes and it's intermittent, then that could very well be an accommodative issue is what you're feeling. You know, of course, we would have to first do the evaluation to pinpoint exactly what your symptoms are to data, the clinical data, to see what's going on. But that is definitely something, that pain too. And if you've already seen neurologists and everything else is clear in the rest of the brain, then we can definitely go to this point as well and do an
One more
evaluation.
really quick question before we jump right back to the video for the next at-home test is, what about cataracts?
So cataracts is different. Cataracts is in your lens, which is behind the cornea. So it's kind of in the middle of your eye. If you have cataracts and it's causing blur, and if it's hindering you from activities of daily living, then you would just need to do surgery to extract it, when they take out the cataracts and put in an artificial lens. In order for you to see clearer. That's different because vision therapy, we're looking at the, even behind, not just the back of the eye, but behind the eye-brain relay center. And so there's a lot of different causes to blur. That one is different. If after the cataracts, you're still, because of a TBI, you're still having intermittent blur or different issues like that, then we would do an evaluation.
So really quick, can you test for, obviously it's very easy to test if you have a cataract. You look to see if the lens is clouded, but can you do TBI eye function tests with a cataract?
Depends on how thick the cataract is. If it's so blurry that, you know, you want to make sure everything else is okay, and then you jump into the neurology part of neurological visual rehab. Having a cataract or not wearing your correction is a different kind of blur. And so if you have that hindering, then the prognosis won't be good for vision therapy.
Okay, gonna jump and share screens. Janine, I saw your next question. So while I'm doing screen share, I can answer that one. I'm so proud of myself. Oops, the next one is this one here. The question is, if you have to do this in person, and this is all being done remotely. So this one is accommodative, correct?
We did this one, so we're on the next one.
Oh, sorry, my bad.
No, you're good. There we go.
Convergence, here we go.
Okay, so convergence and sufficiency. Convergence is your ability to cross both eyes when you're looking at something up close. Both eyes have to come to a very specific point in order for you to see things clearly, for things to not double, for you to not get headaches and eye strain and other symptoms. If you have any misalignment between both eyes and the eyes overcross way before the text or undercross, you will see double. You'll also, you might see things kind of moving on the page. The whole text might be dancing. With double vision, just like with blur, there's a lot of different manifestations of it. It could be horizontal, vertical. With Brian, it was actually both. It was up and to the right. He had two different images like this that he would see. This could be straight ahead, and it could be in different areas. So I have a patient, when he looks straight ahead, everything is fine. But when he looks at like the top right or just different corners, he starts seeing double. And so, you know, and all of that, it just depends on where the injury was or where the developmental delay was in order to have that. One of the main things that happens here is somebody who's born with a misalignment. It's not an eye turn, it's just a misalignment. And throughout their life, they had enough compensatory convergence ranges so they can compensate for it and cross their eyes, and never had a problem or symptom. But then after traumatic brain injury, that part was weakened, that, you know, their compensation for it has weakened. And so now they see it as symptoms of double vision. That doesn't mean the misalignment wasn't there before. It just means the stamina is no longer there.
All right, you ready? We're going to do stop sharing here, and then we're going to go to the screen share to cue him up for this next one. And I have to take it back a little bit to go forward. All right. Action.
All right, so for this one, we are looking at eye crossing. He's basically going to take that same font, that same 12-point text, bring it as close as possible. And then he's just going to know when things start either blurring or splitting into two. So you can actually try this at home. Again, we're not going to measure it in a regular, in the evaluation we would, but right now it's just a quick screening for you to know. So you can take a look at your phone or a paper, hold it where it's aligned with your nose at arm's length, and then make sure you're wearing your reading glasses and everything. Bring it slowly as close to your nose as you can, and then stop when it first blurs or doubles.
Is there a difference from blurring to doubling?
Some people don't see blur and it goes straight to double.
Okay.
And some people have that very beginning. So when it's blurry, it means your eyes are like, they're aligned, but they're about to give out. So it comes before double.
Okay.
Some people don't notice that. And so that's why I say both.
Okay.
Okay. And so if that happens, no matter how old you are, if that happens and you're in your best correction and without cataracts or everything like that, that is a lack of stamina in your eyes crossing. And so that is something.
I have a question. I'm confused. Am I not supposed to be blurry? Am I supposed to be clear the whole way?
No, it can blur, and then after the blur, keep moving, and it may double, and if it doubles, then that warrants an evaluation.
Is there a certain length that I should? Is there a normal length? Let me ask you that.
For blur or double?
Either.
So for blur, it depends, because that depends on, it's age related. So, you know, a kid can go without being blurry all the way to his nose. So that depends on when you are, how corrected you are and everything like that. And depending on the age, it is a calculation we make to see if you're within the norm. But here we're looking for double vision. So if blur happens, then the double vision might be coming. So just keep pushing it. That double vision part it means your eyes are no longer crossing to see, they just gave out.
Okay.
Okay, and so when that happens, it means there is a convergence issue.
Okay. Vision therapy, a question, is not only done in person, like we just said. So in Brian's case, he will be doing it all remote. In my oldest daughter, Alex, she is doing a combination of in-person and at home. So hers is hybrid. And in my daughter Natalie's case, which was back in 2017, it was all in person. So again, I think COVID has turned things upside down to answer that question. We are at 3:37. I do have a hard stop at 3:45. We have more to show you with the videos. But if there's a question or several, I would like to go ahead and have you guys holler out, take your mute off and feel free to ask out loud. It'll be faster than me reading them. Otherwise, I can go forward with the next slide.
Okay. I was just going to say my experience with the monovision, I did that for several years, and then he brought the reading one up so close that I began to get dizzy when I turned to the left because it was so close. And so I just quit and went back to just the long distance and started using reading glasses because I found I was getting dizzy from it. And now I get the sensation that my eyes don't work together. When I have to look hard to the left to make a left-hand turn, for example, I'm seeing double. I mean, I'm seeing out of both eyes separately, not together. And I don't know when it started, if it started and because the monovision made the eyes work separately, or if it's something else.
Okay, so the idea of monovision is to kind of blur one eye until you get to that reading portion. But because you started wearing it later in life, whatever you had before of your eyes working together or aligning wouldn't go away. So even if you actually patch an eye for a year as an adult, when you unpatch it, it's still going to be that if you're 20/20 before, it'll still be 20/20. That part is only affected if you do it on children during their developmental years. So that's one part. I don't know the history. Do you have TBI or like?
I had a concussion 20 years ago where I was out unconscious for 10, 15 minutes, something like that.
Okay. And then have you seen double at any time since then? Like before you switched to your glasses just from the concussion?
No, not that I recall. I've had a couple of weird waving in my lower left eye, where it's just rippling.
Okay.
I've had that a couple of times just in the last 5 years, but those are the only unique incidents.
Okay, so For seeing double, we would have to do like if you're during your annual evaluation to see if you have any misalignment between your eyes. Sometimes that happens. You just hit a certain time where everything you've been using to compensate that just tires out, and then starting to see the symptoms. And so that is something we can re-strengthen in vision therapy to get that compensatory convergence back. The contact lenses though did not mess up anything. So yeah, it's just happened that you kind of felt it after you took them off with the timing. Yeah.
So I do want to add in, your eyes are muscles, right? I mean, they can be retrained just like a bicep. It's pretty miraculous what eyeballs can do. So I definitely would encourage, at least rule it out. You know, that's how I approached everything with my daughter's cases, is let's just rule it out. Maybe this isn't it. It turned out it was, and it turned out, you know, she was able to regain, you know, she could drive again. And that was a really big deal to be able to do that, you know, from not being able to see out of that left eye. So, and her optic nerve was torn, partially torn as well. So it was a doozy in terms of the damage. Do you want me to go forward to the video, Dr. El-Moradi? And then you can do the quick, like it's the cognition part of the...
Yeah.
Okay.
So I can go over all three of them and what they mean. I'll just talk about it, and then we can put the videos after. That way all the questions can kind of be combined in one, just because of the time. So we are going to be looking at three different things. It's from a battery of tests that we do for information processing. And so we're highlighting three different things: figure ground, visual memory, and visual closure. And so these are looking at visual analysis and how you interpret visual stimulus that's coming into your eyes. Figure ground, as the first one, is our ability to distinguish an image from a busy background. And so filtering something out of a busy background and being able to see it. With TBI, information comes in at once and it's overwhelming. And so it's that ability to be able to distinguish one thing that you want and leave everything else in a busy background or visually noisy background. The second one is visual memory, which is our ability to retain information and different like activities, words, images from the past. And so it's just remembering that and having visual memory. The third one is visual closure. And so with visual closure, we are looking at the brain's ability to recognize familiar items or words or images when shown only a small part of it. And so basically filling in the blank in your mind if you see something that is partially there. When we read, we recognize words and envision their completion, and that's what makes us be able to read faster and comprehend faster as we read. And so if you are looking at every single letter and then trying to group the word together, even though you've seen the word in the past, it's going to decrease your speed of reading. And by the end of the paragraph, you're not going to really know what content you just read because you were focused so much on every single letter. Versus filling in that blank in your head and reading a little bit quicker.
All right, so I've got the next cognitive ones about queued up for visual memory first, and we do have a question about prisms to come back to. Okay. So let me do a quick share screen here, folks. All right, and action.
So with this one, we're also, not only are we looking at how, how Brian did and how many he got right, we are looking at his visual fatigue doing it, his stamina needing to take breaks, continue it. So there's a lot of different things. Feeling overwhelmed or frustrated with it is also, we take that into consideration as well.
Yeah, I'm going to slide forward to our next part that we wanted to talk about. It's figure ground is what you have called on the queue up here.
It's bullshit.
Okay. So this one is still sequential memory right here, if you want to move a little bit more forward.
Oh, go a little more forward. Okay.
Yeah, this is still looking at a memory in sequence. So this next one, yep. This one right here is figure ground. So we are looking at the image on top, and you want to find that image, even though it's hidden by different lines in the bottom four answers.
I'm gonna wait a little longer to see if she answers my question.
And so again, I work out of two
Wait a
different
little longer.
we do this, but I was able to develop a way to do it virtually because of COVID and the shutdowns and everything. And so this is part of that battery of testing.
So we have this last one right here, which is visual closure coming up.
I like the bun.
Yep, so just right here we have a completed image on top, and then the idea is to fill in the blanks on the bottom and see which one matches exactly to the filled one on top. And of course, they do get progressively more difficult as we go. I do want to point out that, so Brian gave us the okay to talk about his, the evaluation and what we found.
Mm-hmm.
So he works, he travels for work, he's very put together. If you were to just see him walking down the street, you wouldn't know that there was anything going on. He doesn't have any big symptoms where he's bumping into walls or not seeing 3D. But he actually tested from weak to very weak in a lot of these tests. And so it's very silent. It could be very difficult to know if that person has it or not, just based on how they conduct themselves.
And I want to add in parts that we didn't share, just because we're trying to show you precisely what test will show you what issue is being challenged. He fessed up to Dr. Al-Muradi. He learned how to decipher patterns. And so he was giggling. He's like, I cheated on these last ones, right? And she was like, you're kidding me, right? And so because his injuries occurred back when he first was 10 and then subsequently throughout the year, he learned, he was all of a sudden told he was dyslexic, which he had never been dyslexic. So all of a sudden he couldn't read right? And so while I was going through all of my therapy with Natalie, my daughter, he was listening. And he kept saying, I have that. And so that was why he volunteered, to be our subject, so that we could show this remotely, because, and then also raise the awareness that while Natalie literally did walk into walls, she would reach for a pen or a cup and she couldn't find it. Like that, her depth perception was completely out of whack. But Brian, over these long years, learned how to create tactics for himself. And that's what Dr. Al-Muradi said to him, is like, oh, you learned how to figure it out. And maybe that goes into our last question, which is, are some eyeglass stores better at making prisms than others? And I might need prism glasses for a while, but then not. And what about filters?
Okay, so it really depends on that lab. There are, the way prism is ground in could be different from lab to lab, and so there's also different kinds of ways to grind in that prism in your glasses. And so some places might not have all the options or all the newer options that make it easier to see out of it without all the aberrations and the rainbows on the edges and stuff like that with just newer technology. So yeah, it really depends. It comes down to what technology is being used, what lab is being used. It's usually private practice has the higher end technology than going into somewhere more commercial. And it also depends on how sensitive you are to looking through that prism. So some patients might be okay with any level of technology with Prism, as long as it helps them cross their eyes. Some patients might be very sensitive, and if anything on the edge kind of looks like there's an aberration or a rainbow, then they can't wear it. It makes them nauseous.
And
So maybe look around, look at different options for sure.
And I wanted to add in a couple more other symptoms as well, so which we didn't get a chance to show you. So Brian had reported during his exam with Dr. Al-Muradi, right in the very, very beginning, he said, I'm getting pain, right here. And his eyes would water a lot. And my daughter, Alex, who is doing vision therapy now, she's doing a hybrid at home as well as in office. So she's doing it that way. She initially, and this is, I will say, hats off to vision doctors, because they're probably the most close in terms of doing the same stuff. Very different than what I see with neurologists, very different than what I see with vestibular doctors. I will say vision therapy doctors really seem to be on the same page. So Dr. El-Muradi and my daughter Alex would consult in between Alex's appointments with her doctor in New York. And she, in the very beginning, had to really learn to understand, and this is kind of like an FYI for everybody, you might have to undo what your brain started to compensate, and it might hurt. And meaning she got really, really bad headaches. And it was to the point where she stopped doing her at-home therapy. And I, as the caregiver, would sit there and say, but the way that this is going to be fixed, you watched your sister go through this, is to go through and get past that hurdle. And it wasn't very long. I mean, Dr. El-Muradi, was it a couple of weeks maybe she was complaining about the headaches?
It's usually a couple of weeks. And then the therapy itself, she could do only 3 minutes at the beginning, and that's fine. And we're just building that stamina over time. It changes between patient to patient. It really depends. But usually after a couple of weeks, that eye strain and headaches due to activities is gone. And then slowly those symptoms, by the end, they're done.
Yeah.
But how long that takes depends on the patient and where we're starting from.
Yeah. So I want to encourage you. I've watched my two daughters. One is in the midst of it going through this, and it's made a huge difference for both of them. She will be present with Dr. El-Muradi and Brian for our third webinar, which is kind of like a Q&A, so they can walk through and talk. And I read the transcript of Alex's interview, and I was really blown away with how much she was suppressing and not telling me her symptoms. And she was in school at the time, and she couldn't read a single piece of paper. So she shared with the interviewer that her concentration was 0. She would read a paragraph, and she could honestly say, I don't know a single word I just read. And now, in less than 2 months, it's like night and day. I mean, it truly is like a miraculous rehab. So please ask away. I want to do one quick screen share so you all see on the dashboard where Dr. El-Muradi's first very, very detailed webinar is on the website. So ask, talk, open up.
And the other thing I wanted to talk about was the checklist or intake that we usually do. We usually give it to every patient at the beginning or even during their annual exams at the office. We want to share today so you can take a look at your and subjectively see what's going on with your vision to see if this is something that is right for you to do the evaluation and either pinpoint what's going on or rule it out completely.
And I have a checklist to give you, everyone, too.
At the bottom of it, it says if you have any 3 of the symptoms on the list, it warrants looking into your vision and getting evaluated. However, you know your body. So before you go to any doctor, you know your own symptoms and how it feels. So if the only thing on the list is headaches that always happen with reading, that's enough. You don't need the 3. This is very textbook, but you know your body. If something is bothering you about your eyes, you don't have to have a million of them in order to warrant an evaluation.
So can I, before I pop that up on the screen and I will send it to everybody, do you see the website, the dashboard?
Yes.
Okay, and here is the media tab. If you click on the media tab, these are the different webinars that we've hosted. And the very first one is Dr. Almirati's one of 3. So it'll take a couple of days to get the second one up there, but you can go to all of these and look at the other webinars that we've hosted as well. And really quick, I have to stop the screen share and then go back to the screen share so that I can show you the PDF, or excuse me, go back to the PowerPoint. Oops, oops, oops. Hold on. And can you all see the screen share again with the PowerPoint?
Yes.
Okay, great. And these are, oh, I don't know what just happened there. Hold on. This is the visual symptom list. It is a little difficult. I think it's small because there's probably 20 questions here. But this is what she was referring to. This is Dr. Almirati's email, if anybody wants to email her directly. But if you don't get this down, do I have your permission, Dr. Almirati, to also send this to them as well?
Sure.
Okay. I do not have, unfortunately, everyone, I do not have the ability to put, maybe I can in the chat. I think I can put that file. Can you all access this if I upload it from the computer right now for you? You can try, and if not, I can, I don't know why it's pulling up the wrong one. I'll tell you what, I'll include it in the email because everybody that's registered, I'll just include it and it'll be faster that way, I think. And then I'll include Dr. Almirati's also her email as well too. Does anybody else have any more questions?
Well, the only question I have is I was the one about the perception problem. So, you know, I had a stroke like in March of 2019. And then it's funny because, you know, then they've been testing me and my occupational therapist says I don't see stuff coming from my left. So it's hindering me from driving.
Mm-hmm.
Which got me really annoyed because my hobby was racing cars before. So can't even drive a street car right now. So they say it's because my brain is not processing my issues.
Okay. Are you seeing anything out of that eye if you were to close your good eye? So
yes. Yeah,
vision is there, but it's the information.
My vision's actually fine. But you know, you were showing those. I think Lynn was showing those tests. So I've been going through all that with my occupational therapist. The other thing they've been doing, they've got a TV screen with lights on it, and I have to extinguish the lights as quickly as I can. So I don't know if there's anything I can do at home to try to get my perception better.
Yeah, so in order to know what part of that perception, where is the deficit in there, you would need to do an evaluation. It's a little bit different from OT because we're looking only at vision and neurologically how you are interpreting and how your brain is taking the visual stimulus and that speed of reaction. And so that part is a little bit different than OT. So you need to do the evaluation, the visual information processing evaluation specifically, in order to see what is going on with that eye and whether the prognosis of doing vision therapy on that eye is good or not, just depending on everything else in the health of your brain, basically. You're seeing with your brain, not your eye. And so if you end up being a good candidate for vision therapy, that is something that you can regain through different sessions. Now, as far as the home exercises that you're talking about, that is tailored specifically to what the diagnosis is. So we have to find that first and pinpoint exactly what subcategories you have in the information processing in order to move forward with exercises that you would be doing at home.
Okay, so Dr. Almirati, where are you physically located? Back east someplace, or?
I'm in Southern California.
Southern California. I'm up in Vancouver, Washington. So
okay. So we can do this online. We can do an evaluation. I would just have to, you need access to a printer so you can get some of the stuff prepared before we do the evaluation.
Okay.
and then we can go from there. I would need some history as well. So if you have any, your neurology or your eye reports of your annual exams, we can take a look at that as well. So go ahead and email me with as much detail as you can of what happened after your stroke, any reports you have, and we can go from there.
Okay, I can do that. So I'll do that after Lynn gets the information out. So I'll do that. Really appreciate that. Thank you so much, Dr. Almirati.
And I just put, just so everybody has it, it's dralmirati.vision@gmail.com. And then I put mine also in the chat. So if for some reason you don't get the emails with our follow-up, what I will do is, like I said, I will send the assessment, which is just a little checklist. And there's actually a couple, which I'll include. And I will also re-include Dr. Almirati's contact information as well. And I think it'll be really interesting for like the next webinar, because you can really talk to patients, right? And ask them what the heck. Brian, I'm telling you, he was funny. I do have to jump on another call, so I really wish we could keep chatting, but I think you'll be really impressed with my daughter knew that she could get better, but I don't think she believed it, if that makes any sense. Right? She knew what from her sister, but she was just accepting and tolerating this on her own. So, yeah. Did you have some closing remarks, Dr. Elmer?
Oh, I just wanted to say I do have a Facebook group that is very helpful. It has a lot of patient education on it, and some patients have kind of connected with each other there to just have that support system. And so it's just vision therapy. You can look up vision therapy Dr. Almirati, and it should pop up. And so it's a great tool for just general information about TBI and other issues with vision therapy.
And I'll include that for everyone as well, too. Okay. All right. Dr. Chantel could not make it today. She emailed me, but I told her that we actually are trying to, do what we're doing with everyone here with a group in South Africa. So, we really want to spread the word about this. So, all right. With that, everyone, I will see you in December. And
thank you very much.
You're welcome. I'm glad everybody could attend. Listen, spread the word, right? I mean, bring more people in, because we have to start reshaping how TBI and stroke and other brain injuries are really being managed. All right. With that, I wish everybody a good evening. Thank you.
Thank you. Bye-bye.
Bye-bye.
Thank you.